All right, let's just jump in. I'm excited about our talks today. I'm going to kick us off here. Treating the elbow can definitely be challenging, and so we're addressing topics that are commonly encountered but may sometimes present diagnostic and therapeutic challenges. So I'm going to be talking about I'm going to be doing the introduction talking about the relevant anatomy and some useful surgical approaches when treating the elbow. So I have no disclosures. This is the fist bump of the COVID times in 2021. So I'll try to keep this portion of the presentation high yield, as our audience is mainly composed of surgeons. I know there's some physical therapists as well. And we'll get to what structures are violated in this particular elbow, which obviously there's a lot going on, and we'll talk about that. So the elbow is one of the most highly constrained joints in the body, and the goal of the elbow, or the purpose of the elbow, is to place the hand in space. And there is a delicate balance, and when this balance is off, the joint can trend towards both instability and contracture, which is pretty interesting, and we'll talk about why. All right, so in terms of the bony structures of the elbow, there's 3 bones and there's 3 joints, and we'll get to all of them. So at the trochlea of the humerus, there's 300 degrees of articular cartilage, which is pretty unique. The coronoid and olecranon fossa accept their respective processes to increase their bony stability, and Dr. Verk will be talking a little bit more about that coming up here. So in terms of the humerus side of things, I want you to note how distal the medial aspect of the trochlea extends. And that's important to remember, especially when you're reconstructing those comminuted distal humerus fractures. You're reconstructing that spool. And so there's a range of valgus carrying angle that is physiologic and varies within the population. As well as this is also an important anatomic relationship to remember, that there's a 30-degree of anterior tilt that allows motion, and this is matched perfectly with the ulna, which is the stable base of the forearm. So that anterior tilt that we were talking about of the distal humerus is matched reciprocally with the posterior tilt of the semilunar notch of the ulna, as you can see by the fact that the coronoid tip is more proximal than the olecranon tip. And so that is a bony buttress to prevent posterior subluxation of the joint. So the actual anatomy of the joint, of the ulnohumeral joint, it's been described as a loose hinge, and some useful external landmarks that you can use for the center of rotation that's important in surgery of the elbow is the anterior inferior aspect of the medial epicondyle and the center of the arc of the capitellum. However, this is a moving target, meaning it does change through the arc of motion, in flexion and extension. And so some describe it as a screw displacement axis that actually changes, like we said, throughout the arc of motion. And this anatomical fact makes it difficult to recreate or reproduce with implants and arthroplasties. And that's why there's been a trend towards dynamic X-fixes, which we'll get to later. All right, let's talk about the ligamentous anatomy of the elbow. So essentially, they're just capsular thickenings, but the anterior capsule is an often forgotten structure, but it is a real structure. The fibers are arranged in a transverse and a radial orientation. They attach at the tip of the coronoid, and they do contribute to stability of the elbow, especially in extension. And I can't stress this enough, especially in those terrible triad injuries and instability cases. This is a big contributor to stability. On the medial side of the elbow, there's 3 ligaments: the anterior oblique, the posterior oblique, and the transverse ligament. Okay, the anterior oblique ligament is the strongest, and it's the most significant stabilizer to valgus stress in the elbow. It runs from the antero-inferior ridge on the medial epicondyle, as you can see here, to a point roughly 3 millimeters distal to the ulnar articular margin on the sublime tubercle. This anterior oblique ligament is subdivided into 2 bands, the anterior and posterior. And the anterior, what I want you to know about the anterior is that that's the one that's isometric throughout the arc of motion. Okay, the posterior oblique is more of a triangular ligament, and it's tighter in flexion. It's shaped like a fan, and it inserts along the greater sigmoid notch. All right, so moving to the radius. The head and the neck of the radius is in 15 degrees of valgus, and that's important to remember when you're fixing and replacing this. In the graphic, this graphic here, you can see that in cross section, the head of the radius is not a perfect circle, it's elliptical. And so that means that the center of rotation that coincides with the center of the neck is not the center of the head. So with progressive forearm pronation, as you move down on this diagram, the center translates radially, which then has implications in stability. And then with respect to the forearm axis of rotation, it's important to remember that it runs from a point center of the radial head to the ulnar fovea at the wrist. Now moving to the lateral side of the elbow, the annular ligament attaches to the anterior and posterior margins of the lesser sigmoid notch, and it holds the radius to the ulna. The radial collateral ligament is sort of a blends in with the annular ligament and stabilizes the radial head. This one is uniformly taught through the flexion arc. And then the LUCL, which we commonly think about, inserts on the supinator crest of the ulna, and that's stable also throughout a full arc of motion and does play a significant role in dislocation. And I think of it like a posterior sling of the radial head that comes into play when you're approaching this. So this case that I showed earlier, basically all the lateral ligamentous components, the RCL, the annular, the LUCL were necessarily ruptured to allow this sort of injury. And so those ligaments all needed to be addressed in performing surgery, in addition to aligning the skeleton, the skeletal anatomy. All right, so let's move on to some useful surgical approaches. And so now you're using the knowledge of the anatomy that we just went through, and you can kind of plan which approach is best for the procedure. And like I said, our audience is composed mostly of surgeons, so I'm going to try to keep it high yield. So on the posterior side of the elbow, these approaches can be extensile, and you can even access the medial and the lateral side of the elbow through just a simple posterior skin incision. And that's important because actually fewer cutaneous nerves are violated when you use a midline posterior approach. And obviously, triceps management is the main concern and is the block to visualization here. So just a couple points about using an electron osteotomy. You want to come out at the bare area of the ulnotrochlear joint. Paratricipital approaches is great to mobilize the medial and lateral gutters, and you can fix the bulk of distal humerus fractures, and there's less postoperative restrictions because you're not really violating the extensor mechanism. So now what to do with the triceps? You can split it. This is the triceps split, which is really a workhorse approach for humeral shaft, distal humerus fractures. It can get bloody, and so I would have a low threshold to consider using a drain after surgery. After a triceps split, I rarely protect the triceps in terms of postoperative restrictions. The triceps reflecting approach isn't as commonly done anymore, but you're actually elevating the entire extensor mechanism off of the ulna, and you definitely need to limit their active extension for 6 weeks after surgery, after the repair. The Bryan-Mori approach I included also. It's basically just the medial portion of the triceps reflecting, and this is a good in-between option. On the lateral side of the elbow, I'll spare you sort of the nitty-gritty. I mean, I know most of you all know the Coker and the Kaplan approaches. I do prefer the Kaplan approach. It's more anterior. The interval is between the EDC and the wrist extensors. It avoids the LUCL because it is more anterior. And basically, if you stay anterior to the equator of the radial head, you're basically safe. Always remember that you have to protect the PIN by pronating the forearm. And then extending this incision proximally, the lateral column approach is really great for fractures or for exposing the anterior capsule to do capsulectomies, heterotopic ossification cases as well. So on the medial side of the elbow, there's obviously lots of different ways to approach it, but my approach of choice for the medial elbow is the FCU split. I feel like as hand surgeons, we're very comfortable around the ulnar nerve. And so the approach is just a distal extent of that. You basically follow the ulnar nerve. through the two heads of the FCU and you work anterior, mobilizing the flexor pronator mass off of the coronoid, and you get really great visualization into the joint and on the coronoid. There's no trouble with putting a large buttress plate if you need it for those intermedial fragments. You can see here the medial collateral ligament as well. So summarizing, basically, this joint is an interesting combination of trending towards constraint and contracture, and then obviously you're going to use the anatomy that we just talked about to plan your surgical approaches.